All righty, we'll probably get started here. Good morning, everyone. Happy St. Patrick's Day. I see some green in the room. That's good. First of all, I just want to thank our sponsors for supporting this morning's talk. So that's Novartis and Novo Nordisk today. Our speaker today is Dr. John Dodson, and he comes to us from the East Coast. Grew up in Philly, did med school at NYU, and then residency over at Columbia, and then cardiology fellowship at Yale. And then for his final year of training, he joined the prevention fellowship at Brigham and Women's with his co-fellow Mike Miedema. And so we spent a year together out in Boston and had a great time and got to be good friends. And so since then, we took a little bit of divergent paths. I do a lot of my research on young adults and cardiovascular prevention, and he specializes in geriatric cardiology. So he's currently an associate professor at NYU. He does a lot of research. He's very well funded from a grant standpoint, does some interesting trial work, and so he's going to tell us about geriatric cardiology 2025 and beyond. Dr. Dodson.
Okay. So thank you. I wanted to thank Mike for the invitation to talk about geriatric cardiology. And I actually have a picture, believe it or not. This was in my office for like a decade on one of the shelves, and I pulled it off because I knew I was coming out here. So we did this program in clinical effectiveness together, and this was during the first month of the program. It was a hot July day. I'm down here in the front row, and I confirmed with Mike. He's back here in the plaid shirt. So this is us, and we kept in touch, and I've been really impressed. Mike kind of knew that he wanted to come back here, and he wanted to start the prevention program and really build here, with some of the other folks. And I took a different route, so I study older patients, and there's actually some synergies between geriatrics and prevention, which I'll get into. So I think it's a very relevant talk to give. Now, I'm going to go over my learning objectives quickly. So first, talking about the recognizing importance of aging-related impairments in the treatment of older cardiac patients. Then describe the current clinical and research landscape in geriatric cardiology, and then finally identify future directions for the field. I'm going to start by talking about the demographic imperative. I think a lot of us already know this, but what I've shown here are the US Census figures for growth in the population of Americans aged 65 and older. This starts in 1900 and is projected out to 2060. And along with the remarkable growth of people over age 65, the population age 85 and older is projected to more than double from 6.5 million in 2022 to 13.7 million in 2040. So all of us are going to be seeing these patients on a daily basis more and more. At the same time we're seeing this growth, there's a shortage of specialists in geriatric care, and this is expected to get worse in the setting of these demographics. This article is from the New York Times several years back, and they highlighted that there was a chronic shortage of geriatricians in the US. And this really starts with internal medicine graduates when they're selecting which specialty to go into. In fact, if you look at data from the fellowship match, which I've shown here, cardiology fills nearly 100% of its fellowship spots. Cardiology is all the way on the left. And then geriatrics is all the way on the right. It fills slightly fewer than half, or slightly more than half. And so we have these geriatric programs that are equipped to train geriatric specialists, and there just isn't enough interest in terms of people wanting to go into geriatrics. Reasons for this are complicated, but a lot has to do with the way that healthcare reimbursement is structured in the US and the careers that they're facing after they finish training. In parallel with the demographic changes, as well as the shortage of geriatric specialists, we're also doing more cardiac procedures in our older patients. So what I've shown here are trends in aortic valve replacement from 2012 to 2019. And the overall trend shown by the top line is that there's been a steady increase in valve procedures over this time period. And of course, this is driven by growth in transcatheter aortic valve replacement, which is shown in red. We're also doing more procedures in other settings, including non-ST elevation myocardial infarction. What I've shown here are data from Medicare. This is a 10-year duration. And in this study, even in patients age 80 and above, there was a 39% increase over this time period in terms of use of invasive angiography in the setting of NSTEMI. So we have a combination of an aging population, a shortage of geriatric specialists, and an increasing volume of cardiac procedures that we're doing over time. And this sets the stage where we need cardiologists to be aware of the issues that our older patients face. And what I've shown here is one of the articles, first articles that highlighted this issue. This was published in JACC all the way back in 2011. And it, I think, is the first real foray into the field that we now call geriatric cardiology. What they said in this paper was that mainstream cardiology has become de facto geriatric cardiology, but it still lacks a systematic approach that incorporates age-related complexities into clinical decision-making. These age-related complexities that our patients face are broadly termed geriatric impairments, and I'm going to explain what they are and how they affect outcomes in our patients. So here I've shown a typical patient that I may see in my own practice where nearly all of my patients are over age 70. So this person likely has these traditional comorbidities. They have chronic kidney disease, chronic lung disease. They may have a history of malignancy. They might be diabetic. All of these influence how I'm going to treat the patient. But they also commonly have these geriatric impairments. And these are defined as syndromes that are strongly associated with the aging process, but they're not attributable to a single pathologic entity. So these include things like cognitive impairment, disability, the frailty syndrome, which is defined as this increased vulnerability to physiologic stressors, frequent falls, urinary incontinence, and there are also other syndromes as well. These impairments started to be studied in cardiac patients about 2 decades ago. Anybody know why I'm showing Japan? Mike? So they're the oldest population in the world. And actually the island of Okinawa, which is at the bottom of this map here, this is still part of Japan. They have the oldest population in Japan, and they have the largest number of people over age 100 on the planet. And so the Japanese faced this aging trend earlier than the rest of us. And so they started to do research into these geriatric impairments. And so we had cardiologists in Japan all the way back in, this is 2013 in JACC, and this study looked at gait speed. So gait speed is just how fast you walk. It's a pretty good surrogate for this frailty syndrome that I talked about, where you have an increased vulnerability to stressors. The slower you walk, the more frail you are. They looked at the association of frailty with cardiovascular events after an initial hospitalization for acute myocardial infarction. In this study, they took inpatients with an acute MI, and they measured how fast they walked at the time of hospitalization, and then they evaluated the number of cardiovascular events at long-term follow-up. So people who walked slower were more frail, and what they found was that those who walked the slowest, shown in red, had the highest rate of cardiovascular events, while those who walked the fastest, shown in blue, had the lowest rate. And after adjusting for other factors, this finding remained significant. So our group looked at frailty and the outcome of in-hospital bleeding. This is in the ACC's ACTION registry, so the ACC maintains all these cardiovascular registries. ACTION is a registry for acute myocardial infarction. And frailty in this paper was extracted from the electronic health record. So in the Japanese study, it was directly measured. That's considered a kind of gold standard measurement, but the benefit of using the electronic health record is that you can study a lot of patients. And so we had 130,000 or so patients for this analysis. And our main finding is here with the in-hospital bleeding rate shown on the y-axis. So patients with moderate to severe frailty are shown in light blue, and those with no frailty are shown in dark blue. And we looked at these patients overall, and then we stratified them based on whether or not they underwent cardiac catheterization. So what we found was that the group at the right underwent cardiac catheterization, and if you were frail, you had over twice the risk of experiencing bleeding compared with not being frail. So another geriatric impairment that confers risk is cognitive impairment. This is an early study. This was done out of the Cleveland Clinic. And they used an instrument called the mini-cog. Does anybody know what this is? Has anybody used it? Okay, good, because I'm gonna tell you about the mini-cog. It's one of the best instruments for cognition because it's easy to remember and quick to use. So it involves a patient remembering 3 unrelated words, and then they draw a clock, and that's it. So it's scored on a scale of 0 to 5, and a score of 3 or less is abnormal. And so this was a unique study because these are patients with heart failure. We're thinking about their diuretics. We're thinking about their, whether they need some sort of testing in terms of imaging, but we're not necessarily thinking about their cognition. So they actually did this mini-cog in everybody. And this is an example of the clock drawing exercise. So it's really interesting because you don't really know a person until you have them draw a clock. What A and B show is a normal clock. The patient is asked to write the time is 8:20. They also have to number the clock. C and D are abnormal clocks. And you can see kind of these things that patients do where they're trying to draw their clock properly. This person actually writes 8:20 on it, but it's an abnormal clock. And what they found was that if patients had cognitive impairment, which is shown in red, the risk of hospital readmission or death was over twice as high compared with patients with no cognitive impairment, which is shown in black. And similar to other studies of these impairments, this finding persisted after adjusting for other factors that might lead patients to get readmitted to the hospital. I think this finding kind of makes intuitive sense when we think about what we ask our patients with heart failure to do. They're taking 5 medications. They have, they have to monitor their symptoms. They have all these specialist visits that they're attending. And there's a big cognitive load in heart failure that we're maybe not appreciating. And it also is associated with other things. So if you're cognitively impaired, you might be likely to fall and have a hip fracture and come back to the hospital for a reason that's not related to your heart. I also wanted to mention the Silver AMI study. I became involved with this during my cardiology fellowship. The idea behind Silver AMI was to integrate all these geriatric impairments to determine the risk of adverse events in 6 months. The study enrolled patients from across the US at the study sites I've shown here, so all over the US, even Hawaii. We actually had a couple sites in Minnesota. I don't know if you guys were one of them, but they enrolled more patients than any other study in terms of directly measuring these geriatric impairments. And as part of the study, this is what we measured. Most of these were missing from cardiology studies that had been done in the past, or like the Japanese study, one impairment had been measured like gait speed, but not the other. So we measured all of these impairments in every single patient. We published the mortality risk model in the Annals of Internal Medicine, which I've shown here. The timing was unfortunate. This was 2 months before the COVID-19 pandemic, and after March, everybody was doing COVID-19 research, including cardiologists. So I think this kind of got lost in the shuffle of the pandemic. It's still one of the most important things I've done in terms of my research, and I'm going to show why in the next slide. So these are the essential findings of Silver AMI. So if you look at the GRACE risk score, this is a mortality risk model that was published by Kim Eagle back in the 1990s. And if you compare that with a model that incorporates geriatric impairments from Silver AMI, the model that includes geriatric impairments performs better, as shown by the AUC for the 2 models at the right. So the Silver AMI model is in purple. The AUC for 6-month mortality is 0.84. So that's a really good risk prediction model. And what we found in the model, the final model shown here at the bottom, is that impairments in hearing and mobility, as well as weight loss and low patient-reported health status, improve the ability to predict the risk of mortality at 6 months when added to other risk factors. So we also had things like creatinine, things like ejection fraction. Those matter, but these impairments matter as well in patients in terms of what's going to happen in the next few months. So in summary, we've seen that the US population is aging and geriatric impairments are common in our older patients. And I also think at this point it's fairly definitively established that among cardiac patients, these impairments influence patient outcomes. So I'd like to move on to what we're doing clinically at NYU, and then I'm going to pivot back to some of the research that we're involved with. So we have a geriatric cardiology program. I started it in 2014. There are 3 components to the program. We have an outpatient clinic, a multidisciplinary patient conference, and then development of clinical tools to help in geriatric assessment. The clinic, which I run, provides care for older patients. They typically have multiple comorbidities and geriatric impairments. My oldest patient currently is 101. Oldest patient in the practice has been 107. And in addition to the longitudinal care, we provide second opinions. Sometimes these are self-referred. People find us online. Sometimes actually from other cardiologists where they have somebody who's very old. They don't know exactly what to do in terms of their medications or whether they should have a procedure. Typically, as part of the initial intake, we'll consider principles of geriatric impairment, including cognition, somebody's physical function, their history of falls, orthostatic vitals, and this is individualized based on the patients that we see. Here's an example. This is a real clinic patient of mine. This is somebody who had, their family reported that they were having some memory problems on an initial visit. I performed the mini-cog. This is a clock that they drew. This is clearly abnormal. And at this point, what I'll do is I'll refer these patients to our memory center. So we have memory specialists who are equipped to work this up. I don't try to play neurologist, but I do serve as a point of entry to identify these problems early and then work downstream with other specialists in terms of collaborating on care. Here's some sample referrals from our practice. I think the most common symptom that I see is unexplained dyspnea. This is very challenging in older patients. Maybe it's cardiac, maybe it's pulmonary, but it also could be things like kyphosis from compression fractures. It could be sarcopenia, which is this geriatric syndrome that involves generalized muscle loss. I put refractory orthostatic hypotension. This is kind of a niche diagnosis. I've seen a bunch of these people recently, and it's usually in the setting of something like Parkinson's disease. Management is a combination of lifestyle modification and careful medication management. But again, making small changes and individualizing therapy is key here. In terms of the multidisciplinary conference, we've been running this for 10 years now, and it's a venue where cardiologists and geriatricians get together in the same room. We talk about difficult patient cases. So what I've shown on the left is one of our early patient conferences. At the right is where we migrated to Zoom during the pandemic. We're now back to in-person, and we'll get up to 30 attendees per meeting. And so we have cardiology, we have geriatrics, we have sometimes cardiac surgery comes, electrophysiology will come sometimes, neurology, depending on the case. And there's lots of cases where we need expertise. The idea is to run this similar to an oncology tumor board. You have multiple experts in one place. And I have some sample cases in the next slide. Often it's somebody who gets readmitted to the hospital a lot. Is there a way that we can keep them out of the hospital that we haven't thought about? The second and third cases are difficult procedural decisions. Should we intervene or should we not intervene? And so at those cases, for example, cardiac surgery will come. I didn't list it here. We had an interesting case of somebody with a pacemaker where the family was asking to deactivate the pacemaker, and we had a conference about the ethics of that and the geriatricians and the cardiologists. And sometimes people disagree, and that's okay. But the idea is to kind of get all of our heads together and try to make a decision collectively. The third thing is development of clinical tools to help people who are seeing these patients. And I have a few slides on the Geriatric app, which has been our most successful launch to date. We have a couple apps that we've developed. Geriatric has some traction. So I highlighted this problem earlier in the talk where we have an increasing number of older patients in the US. And so all of us are going to be seeing more and more of these individuals, especially given the limited number of geriatricians. And the geriatrics community has advocated for decades that these impairments should be measured in other people's practices, and the truth is we're not doing it. And I think one of the problems is that we don't know what these instruments are. We don't have access to these instruments. And so this led us to develop this app where we put all the instruments in one place. And I'll show it here. So this is called Gerikit. This is a one-stop shop for geriatric screening. The app has built-in assessments for geriatric impairments, and it takes you through the logic of each instrument. There's an educational component, so if trainees are using this, they can link to the original literature. And we decided to offer this for free. So we're not trying to make money off of this. We just want people to use this tool to take better care of their patients. To date, it's had over 5,000 downloads. It's also been integrated into the medical curriculum of students at NYU and UNC. And other medical schools, I think, are going to sign on soon in terms of training their students in geriatrics. This is an example of an instrument called the 30-second chair stand. This is a measure of fall risk. The app takes the user through the logic of this instrument, and then the result is shown at the right. So simple, easy to interpret. And then this, I know it sounds like I'm marketing this, but again, we're not. This is a free app, but we recently launched Gerikit 2.0. And 2.0 added instruments to measure delirium, frailty, and hearing impairment. We were hearing from people that we should have more instruments that were useful in the inpatient setting. And so, for example, delirium, very common in hospitalized patients. We might not know what's a component of the delirium instrument, so we have a delirium instrument in Gerikit. There's a QR code, might be hard to scan, but you can also download it either in the App Store or the Google Play Store. So this is functional for both iOS and Android. And I'd like to mention there are other geriatric cardiology programs in addition to our own. So here's some other programs I'm aware of. And the key point is that each of these programs has one or two dedicated cardiologists that really care about this. They've partnered closely with their local geriatricians. Most of these programs also perform research. They actually have a fellowship up at McMaster, only fellowship I know of. A lot of people get to this field by doing clinical training in cardiology and then either clinical training or research training in geriatrics. And so I did research training in geriatrics. I think know the issues well enough to incorporate them into my practice. Notably, also the American College of Cardiology has a member section for geriatric cardiology. This serves as a home for people with an interest in the field. The section started around the time of the JACC paper that I showed at the beginning of the talk. Since that time, it's grown to over 1,000 members. I'm showing Scott Hummel here. He's at the University of Michigan, takes care of a lot of older patients with heart failure with preserved EF. And his interest is whether you can use diet to improve outcomes in patients with HFpEF. So again, lots of people with interesting research and clinical interests that overlap. Okay, so I'll move on now to research, and I'll spend most of the remainder of the talk on the RESILIENT trial. This is a trial of mobile cardiac rehab that just came out. And I needed to provide some background here. And what I wanted to say about these pivotal randomized trials that I've listed is that I think research is so important in the geriatric population because back when I was a cardiology fellow, I would cite these clinical trials on rounds, and you look at the age, and most of these were fairly young, and some trials even had an upper age limit of enrollment. So like if you were 75 or over, you couldn't get into the trial. And so I was in the ICU taking care of an 80-year-old, with heart failure, and I didn't know how to apply the evidence. And it wasn't clear whether what worked in younger patients worked in older patients. I've listed partner at the bottom. This is the original trial of transcatheter aortic valve replacement. And this was an outlier, and I think the partner investigators deserve credit for enrolling an older patient population with a ton of comorbidities, and this is by the nature of the condition, which was inoperable aortic stenosis. But most of the other studies had patients who were younger. So this issue was highlighted in the paper I've shown here. This was published in Circulation back in 2016. The authors on this paper included many leaders in the geriatric cardiology community, and they came up with a specific set of recommendations for trials in older patients. So here are two of the recommendations. So one is to not exclude patients from enrollment based on age or comorbidity, so let them into the trial to see if this works. And the other was to include outcomes beyond mortality, such as physical function and independence and quality of life, because these have repeatedly been shown in surveys of older patients to matter to them. So if you ask somebody who's in their 80s or 90s, what do you want? It's not just keep me alive for as long as possible. It's that I want to live independently. I don't want to be short of breath. That's what people really cite as important to them, and these outcomes were missing from a lot of the cardiology trials. So this leads us to the example of mobile cardiac rehab in the Resilient trial, which was largely designed in response to these recommendations. Before discussing this trial, I wanted to provide a brief overview of traditional cardiac rehab. This has been in existence for decades. It's chronically underused. The program is delivered at a medical facility. This looks very similar to a gym. It also has telemetry, and it has exercise therapists who are directly delivering care. There's a healthcare provider on site who's a cardiologist or nurse practitioner. The components include a combination of a baseline medical evaluation, structured exercise, lifestyle counseling, psychosocial support, education. Typically, a program runs for 36 sessions over a 3-month duration. I know Mike has recently launched a program here, so credit to Mike for doing that, because these programs are more sparse than they should be, and there's a lot of reasons behind that, but we know that they're effective, and I'm going to show here why. This is a review of exercise-based cardiac rehab for ischemic heart disease. This is the most studied condition, although there's also some evidence in systolic heart failure about effectiveness. This is a Cochrane review from 2021. This is a synthesis of the evidence to date. There were over 23,000 patients with ischemic heart disease who were included. And what they found was that at both short and long-term follow-up, there are improvements in outcomes that included myocardial infarction, hospitalization, and cardiovascular mortality. So there are reductions in all of these events with traditional cardiac rehab. But there are also challenges, and these include low rates of initial referral. So about 25% nationally are referred to cardiac rehab. This matches our local data at NYU, so not everybody who's eligible gets a referral in the first place. There's this problem of attrition where people stop going after the first few visits, either because they don't feel like it's useful or they have too many competing demands. And barriers are especially high the older you get, which I'll show in this next study. This was a study of Medicare beneficiaries, and they looked at cardiac rehab participation and completion. And on the x-axis here are age strata, so 65 to 74, 75 to 84, and then greater than 85. White means that people in this age category never attended cardiac rehab. And as we can see among the oldest men and women over age 85, there was the lowest rate of cardiac rehab initiation. So if you look at women over the age of 85, it's less than 10%. And there are lots of barriers for this population. It's clear that some people in this age category simply can't participate. They have a disability that just makes it impossible to do the exercises that they're supposed to. But I think for others, they may have trouble getting to the rehab center. Maybe they don't drive. Maybe they have competing medical visits with other specialists. And so there's clearly a problem in this effective intervention not getting delivered. So this gets us to mobile cardiac rehab and how this may be a useful alternative to traditional rehab programs. So I wanted to define mobile cardiac rehab. It's basically cardiac rehab delivered remotely that uses portable electronic devices. Usually this is a combination of something with a screen and an activity tracker. So this could be a tablet device to view data and a Fitbit app to track activity. The monitoring is typically combined with remote involvement of an exercise therapist, and so there's a human component. This therapist provides counseling on what activities to do. This person helps to reinforce the patient's goals. The general idea here is to replicate the benefits of traditional in-person cardiac rehab in the home setting. And the evidence generally points towards these programs having similar effectiveness to in-person programs. And the reason I put the star here is that there's very limited evidence in older patients, which I'll show. Despite its potential benefit, mobile cardiac rehab is not reimbursed. There are a few key exceptions. So the VA pays for it. The Kaiser system pays for it. And during the COVID-19 pandemic, it was paid for everywhere. So during COVID-19, NYU delivered remote cardiac rehab. And then when the pandemic stopped, the reimbursement went away. The VA and Kaiser can do it because they're integrated health systems. So they've decided it's important and they pay for it. In terms of the evidence here, I've shown a recent review of these home-based mobile rehab programs. This highlights their general effectiveness. It was a meta-analysis of 14 randomized trials comparing mobile rehab versus traditional rehab. And their main finding was that the outcomes were generally equivalent, but I wanted to note that the mean age was less than 65 years in all but 2 trials. And those 2 trials had a total of 274 participants. And we have reason to believe that older patients may respond differently to an intervention like this. So there's an extensive literature of the technology barriers that this population faces. And some older patients can easily use a smartphone or Apple Watch. I have those patients, they're very tech savvy, but it's not all older patients that we see. So some people have definite limitations to engaging with digital care. So aside from having very few older patients, which is the first point, a few other limitations. So some of these mobile studies have had non-randomized designs. Others have had these bespoke interventions, so it's developed for this medical center and it simply doesn't scale when you try to deploy it elsewhere. And also, as a researcher, anybody who's tried to publish negative studies, I think, knows there's a pretty strong publication bias where journals want to publish things that work. And so I'm not sure how many trials didn't work out that didn't make it into the literature. Despite the general lack of evidence in older patients, we had a number of technology companies that were marketing mobile rehab programs to medical centers claiming that they were effective. So here's one example. This is a company that actually ended up partnering with us for the Resilient trial. And I think there really was insufficient evidence in older populations, but these people could stand to benefit the most. They have the highest burden of ischemic heart disease, and they have lots of deficits that could be improved by cardiac rehab. So this brings us to Resilient. This was published in JAMA Open in January, and we presented the results at the ESC meeting last summer. So our question for the Resilient trial was simple. So does mobile cardiac rehab, abbreviated MHLCR, improve functional capacity in older adults with ischemic heart disease compared with usual care? Resilient was a phase 2, multi-center randomized pragmatic clinical trial with blinded assessment of the primary endpoint. We used 3-to-1 randomization with more people assigned to MHLCR in order to have enough data to understand engagement with the technology. The study was funded by the NIH. The coordinating center was at NYU Langone Health, and we had 5 study sites, which are listed at the right. These were all in the US. To be included, people had to be over age 65 because we wanted to see whether this is effective in the older population, have a recent hospital visit for either acute myocardial infarction or a coronary revascularization procedure, and speak English or Spanish. Exclusion criteria designed mainly for safety, so people who had severe osteoarthritis, people with progressive movement disorder like Parkinson's couldn't get into this study because we were delivering it remotely. This is our study flow diagram. So after screening and informed consent, participants underwent a 6-minute walk test. They were considered a screen fail if they experienced an adverse event. And if not, they were randomized to either usual care or mobile cardiac rehab. And then at 3 months, they underwent measurement of the primary and secondary endpoints that I've shown at the right. The study intervention, 3 core components of Resilient. So the first was a mobile cardiac rehab software platform. We used the platform from a company called Moving Analytics. It was delivered on a tablet device, and this was provided at no cost for duration of the study. It was also cellular capable, so there are no issues with people having to have home Wi-Fi or that sort of thing. The second component was counseling by an exercise therapist. This person met with the study participant at baseline, and they followed up weekly over the phone. Participants were instructed to exercise 5 out of 7 days with a goal of 150 minutes per week at moderate intensity. The third component was this remote physiologic monitoring of step count and blood pressure with the devices that I've shown here. These integrated with the software program, and these were viewable by both participants and the exercise therapists. I'll go over the endpoints. Primary outcome was change in functional capacity measured by 6-minute walk distance between baseline and 3 months. This is a functional measure. Again, it's been repeatedly cited as something that's important to older patients, and that's why we used it. Secondary outcomes were health status measured by the SF-12, residual angina measured by the SAC-7, and then disability measured by instrumental activities of daily living or activity of daily living impairment, abbreviated ADL and IADL. Okay, so in terms of the results from Resilient, this shows enrollment and follow-up over the 3-month study duration. We had 298 participants randomized to receive mobile cardiac rehab and 102 randomized to receive usual care. Study completion at 3 months was 90.9% in the intervention arm and 83.3% in the usual care arm. This slide shows the demographic and clinical characteristics for the Resilient sample in both arms. So to highlight a few details, median age was 71 years, slightly over 1/4 of the participants were women. The most common enrollment criteria was after elective PCI, and there were patients in both arms who still received traditional cardiac rehab. This is a pragmatic clinical trial, so this is actually allowed. This was low in both arms, higher in usual care, but it was still only 25% in usual care. And this is important because this is a background rate nationally and also the rate at NYU. And so it's really a comparison of usual care versus a mobile intervention rather than 2 arms, both of which are high performing, because we wanted to see if mobile cardiac rehab was better over the background of usual care. Okay, so this is the primary endpoint of change in functional capacity between usual care, shown on the left, and the intervention arm, shown on the right. The y-axis is change in 6-minute walk distance between baseline and 3 months. And each patient is plotted individually. So the mean difference between intervention and usual care arms was 15.6 meters. There was a 95% confidence interval between -0.3 and 31.5. This was not statistically significant based on a threshold of a p-value less than 0.05. I know to the researchers in the audience, this seems close, but actually a clinically significant difference is considered 25 meters or greater. So it was powered for 25-meter or greater difference. We actually had better follow-up than expected, so we had a little more power than we thought, but still 15.6 meters is not considered clinically significant. This slide shows the secondary endpoint of general health status based on the SF-12 at 3 months, with the mental component score on the left and the physical component score on the right. As shown, the mental and physical component scores were similar between treatment arms at 3 months. For the secondary outcomes of residual angina at the left and disability at the right, we also found there was no meaningful difference between the intervention and usual care arms. So I think what's important here is that all the outcomes are tracking in the same direction. It's not like one outcome is markedly better. Everything looks like it's similar between arms. We did perform pre-specified subgroup analyses to evaluate for treatment effect heterogeneity. As I've highlighted here, there was a 36.6 meter improvement among women and an 85.2 meter improvement among people who underwent CABG. So these findings are hypothesis generating. We weren't powered to look at these differences, but I think this is an intriguing finding that we had these subgroup effects. In terms of data for safety, overall rate of adverse events was low. We did have 1 hospitalization in the intervention arm, which was a fall related to exercise that we told the patient to do. So we had 1 event out of 400. But I think this is important data because the safety concern comes up again and again, and it can be delivered relatively safely in this older population with the exclusion criteria that I mentioned. So we had several limitations. This was a pragmatic trial embedded in clinical care. As I mentioned, people still could attend traditional cardiac rehab if they were referred. In addition, nearly 3/4 of eligible patients declined informed consent, which may limit the external validity of our findings. This was a surprise. I thought people would want to do this trial. We're giving you an activity monitor. We're giving you a tablet device. We're delivering exercise remotely. Anecdotally, some people felt they were too sick. Other people felt, I got my stent, I'm better. And this happens. So it was more challenging than I thought to deliver this remote exercise intervention to a large number of people. We also launched the trial, I think, 2 months before the COVID-19 pandemic. So it was kind of like I published this paper in the annals and we launched Resilient, and then COVID happened. So we got back on our feet and finished the trial, but we did have some challenges along the way. So to summarize Resilient, this is the largest trial of mobile cardiac rehab to date in an exclusively older adult population. We found that compared with usual care, mobile cardiac rehab increased 6-minute walk distance, but it did not achieve a clinically significant 25-meter improvement in functional capacity. Secondary outcomes also were negative. Adverse events were very rare, and several findings, including improvement in functional capacity, among women, I think deserve further study. So I think that ultimately Resilient provides an example of a cardiovascular prevention trial geared towards a population where the results were different than they were in younger populations. And my guess is this had a lot to do with how patients interacted with the technology. We're currently looking through our engagement data to try to sort out exactly how frequently and how well people engage with the digital platform. Because if you know, the saying drugs don't work in people who don't take them, if you prescribe this to somebody and they never log in, it's not going to be effective. I had a few slides on the research agenda moving forward. I did want to have adequate time for questions at the end, so I'll go through this relatively quickly. I wanted to note, so some of the newer pivotal randomized trials, patients are older. And this is definite progress in the field. So if you look at some of the structural interventions, MitraClip, tricuspid repair, as well as some of the newer trials in NSTEMI, patients are in their 70s and 80s. And this has been a real paradigm shift. And I think investigators are sensitive to the issue that the trials need to match the population that you're ultimately going to treat. I wanted to close with one interesting future potential direction for preventive cardiology. Again, some overlap with what Mike's doing, I think. And this is a potential to prevent dementia. So I think as everyone knows, dementia is a disabling condition. It's expected to rise as our population ages. And a considerable subset of dementia is vascular dementia. And this is largely due to uncontrolled cardiovascular risk. So this is one of the largest studies of dementia prevention to date. This came out of SPRINT. SPRINT was a trial, I think, as most people know, of intensive blood pressure control, and they had a sub-study called SPRINT Mind, which I've shown here, was published in JAMA back in 2019. And SPRINT Mind had over 8,000 patients enrolled in SPRINT. This compared a target blood pressure of 120 versus 140 millimeters of mercury. The mean age was 68 years. Over one quarter were over age 75. Participants were followed for a mean of 3.3 years. Cognition was measured with something called the Montreal Cognitive Assessment, as well as some other instruments. Their main finding was that intensive blood pressure control significantly reduced the incidence of mild cognitive impairment, although there's no significant reduction in dementia. The difference between these two conditions is that dementia involves impairment in daily functioning. So dementia is a more severe condition. But even though they found a difference in dementia, the main SPRINT trial was terminated early for benefit, and so it may have been underpowered to detect this outcome. I wanted to show the survival curves for the incidence of dementia over time. We can see that with intensive treatment, it's intriguing. There's a reduction in dementia over the long term. The confidence intervals still overlap, but it looks like there's a trend. And we know that dementia accrues over many years. And so I think this is a very interesting finding and might be something that we could apply to our practices when we're talking about our patients in prevention of dementia. Has anybody heard of the preventable trial? Mike, a couple people. So in this trial, they're looking at statins rather than blood pressure control for prevention. Again, looking at, well, I'll get to the outcome, but I think what's especially notable about preventable is that it's the first randomized trial to test whether primary prevention statins are effective in patients age 75 and older. So 30 years ago, we had trials that excluded patients over a certain age, and now prevention is saying if you're under 75, we don't want you. We want people 75 and older. And what they're studying is a comparison of atorvastatin 40 milligrams versus placebo. They're aiming to enroll 20,000 patients over 4 years, and their primary outcome is dementia or disability, with a secondary outcome being cardiovascular events. And so again, there's a focus on prevention of dementia and whether statins can help. I've showed the methods paper here if anybody is interested in reading more. I'm highlighting it because I think it shows how far we've come in clinical trials in terms of focusing on older patients and what happens when we treat them. And I think the question of statins for primary prevention, I mean, this is something for me, it comes up on a weekly basis in my patients. And it's not just do they prevent heart attacks, but really the cognition question comes up all the time. And I think preventable will give us insights, dementias and outcomes. So we can tell our patients, you know, this prevents dementia, or it doesn't, or it's you know, or it was a negative study. But it will provide very important evidence, and I'm excited about the results. So to summarize, I think there's an imperative for the field of geriatric cardiology given aging demographics, both in the US and elsewhere. There are a small number of clinical programs that have been launched. These are led by 1 or 2 cardiologists at each center that have partnered with their colleagues in geriatrics. Myself and other colleagues in this field have a broader clinical goal of educating people about the principles of geriatric assessment, including cardiologists. And so through the GeriKit app, which we made freely available, these tools are at people's fingertips. And then in terms of the research agenda, I still think we need more clinical trials in our older patients that include outcomes that matter to them, such as function and cognition. So that's the end of my talk. Thank you. I'd like to thank Mike and everyone else. Happy to take any questions.
Thanks, John. Great talk. Questions? Dave.
Thank you for the talk. I really appreciate hearing your perspective on this topic. I guess my issue would be, my dad passed away this last summer at age 96. In the last 2 years of his life, he participated in multiple different therapy sessions. And I don't think he was unique to his age group, but he was very good and looked forward to having the therapist show up in the room and do his physical activities with him, and he was a good participant. And then the therapist would always say, now, between now and the next time I see you, I want you to do these exercises that we practiced today. I guarantee you he never did it once, except when the therapist showed up. And I said, I think the one indice I'd be interested in seeing is basically what I call the motivational index. You know, I think it's a huge issue for older patients. I see it in my patients every day. And I don't see it being measured in a lot of the indices that you present on your apps and that. And I just would be interested in your perspective.
Yeah, it's a very important comment. It's critical, and you know, I feel the same when I see a patient twice a year. Like I have no idea what they're doing when they're not in the office. And there's this concept of hovering where if you could somehow have healthcare with the patient at all times, that's monitoring them or nudging them to be more healthy, that would be a big win. And there's companies that are working on this and trying to kind of modify people's behavior and trying to maybe reinforce or motivate people who don't have that motivation, because absolutely, like when you're not in the room with the patient, you don't know what's happening. Like I tell my patients, go exercise, and some of them come back and do, and some of them just, you know, they have no interest or motivation. I think there's some interesting work. You know, I'll say one thing we're trying to do is feedback information from wearables into our electronic health record. It actually can be done. But we just haven't linked it yet with cardiology. We've done some work in remote blood pressure monitoring, but somebody's Apple Watch or Fitbit, or your phone, honestly, it just tracks your steps whether you want it to or not. So that can be integrated in the electronic health record. And I thought it would be great to pull that up to a patient and say, I see you did 10,000 steps a day last week. That's great. Maybe that's some of it, but I don't think it's all of it. What I can say with resilience, so we haven't published this yet, but we've looked at the engagement data, and I mentioned that we had the unbalanced randomization to try to have more data for engagement. If you are highly engaged with the program, meaning if you log in almost every day, and if you communicate with the exercise therapist, and if you do what you're supposed to, your change in 6-minute walk distance is like 55 meters. So those people did extraordinary. If people don't engage, some people kind of did it a couple times and got frustrated, or they just weren't interested, your walk distance changes 20 meters. And so engagement absolutely matters. But I think there's a lot of work we need to do in terms of improving engagement and interest in doing things when we're not there with the patient. So great question.
Otto.
I have two questions. And so in your trial, you say that you didn't find any difference between your intervention group and the usual care group. But would you say that would be maybe a more cost-effective method to have the remote care than to have a patient, you know, get in the car and then go somewhere else and then pay the cardiac rehab? So did you analyze costs?
It's a good question. I can say that it's not something I would say the overall cost of the technology is low. And the cost of the labor is also relatively low. And so if the mobile platforms worked and could be scaled, it would be much more affordable than the traditional rehab we do. I think that's pretty clear, because traditional rehab, you know, our rehab is it's in Midtown Manhattan. It's basically like a floor, and that's expensive real estate. And you know, I was talking to Mike about the reimbursement. It works because it's considered part of the hospital, and so that's reimbursed under a higher rate. And that we actually at our rehab, we have patients from NYU, Cornell, Columbia, Mount Sinai. They all come to us because we've made it work, and other institutions have really struggled with that. So I think that it's costly to deliver. The reimbursement is challenging to work out. I think the ideal situation might be, but again, this would be hard to deliver if you could have kind of like a hub and spoke model where you had other physical rehab programs that were closer to patients and easier for them to get to. Again, with the mobile platforms, a lot of it has to do with motivation. And if when you show up to a rehab class in person, there's kind of an accountability there because there's other patients exercising and there's a therapist who's telling you what to do. And with the mobile platform, you have to like log into it and nobody's like watching over your shoulder. And I think that might be part of the reason we found it was not effective.
So the other one, sorry,
Sure.
So I read a book by Elizabeth Blackburn. She got the Nobel Prize for the telomerase, and then read the book with David Sinclair, and they indicate several factors that could delay aging, and they had the research to show. So would you say that aging has become a modifiable risk factor?
It's another talk. I'll come back. It's funny though. So I'd say this. So I commuted to Grand Central Station, and I walked in on like Thursday, and there's like an event space. It's called Vanderbilt Hall. You walk in. There's a Medtronic had a display where they're giving out coffee, like at the ACC, and there was a big sign that said, "We're all going to live to 150." And so like industry is like really bought into this idea of us all aging to 150. I don't know if the science bears that out, but what I would say is if we control our cardiovascular risk factors, and then again, I have another talk kind of on where we're falling short on prevention. If you look at hypertension, we're only treating hypertension well in half the population with hypertension. Like, it's low-hanging fruit. Or it seems like if we could treat that better, and maybe we could get people's LDLs to 20, and maybe people could exercise, I think people could live a lot longer. You could prevent a lot of the morbidity that we see.
How do you balance the influence of these geriatric impairments with the complexities of polypharmacy?
Good question. Polypharmacy is it's not an impairment in and of itself, but it's one of these related concepts. And actually, Gerikit has a polypharmacy tool. So there's actually something you click on, and you put the number of meds. And I think we define polypharmacy as 5 or more medications. Polypharmacy it's a major issue. And one of the things I try to do, I wouldn't say that I would stop medications if somebody was frail, but I'm definitely more hesitant to start medications in the setting of somebody who has a lot of impairments. I think it's definitely something where deep prescribing is another kind of research area, looking at kind of like statins and patients at the end of life. Famous study, it's like 20 years ago now, where they looked at statin prescription in people in nursing homes at the end of their lives, and like 50% were getting statins in the last week, and we've kind of backed off on that, and we're trying to de-escalate therapy. So I think again, polypharmacy is something that's a problem in older people. I try to de-prescribe if I can.
Would you say that for cardiology, that you think in general we are too aggressive with our elderly patients, or not aggressive enough, or should we don't individualize things enough?
Geriatricians tell me that we're too aggressive. I don't know if I'm like somewhere in between. So I go to these geriatric cardiology conferences, and one thing we do is like antiplatelet therapy forever. Another thing we do is like systolic blood pressure below 120. Geriatrics tends to be very conservative. I think Sprint changed my mind, and I've seen studies on there's a question of frailty and fall risk, and are we overtreating our patients? And I think in some situations, yes. So I think it does need to be individualized. And in some patients, if they're coming in and they have orthostasis, or they have dizziness, or their heart rate's 45 and they're on metoprolol, I will back off on the medications. But I become more aggressive over time, I think, as the literature comes out.
Sort of a follow-up. So what is your perspective on guideline directed medical therapy of heart failure in this very elderly patient?
Yeah, it's a good question.
What do we really know?
Yeah, I think with the heart failure I see, because of the age population that I see, it's mostly HFpEF, because most of the systolic heart failure patients are younger. With HFpEF, I think some of the more recent trials, again, have changed my thinking on that. It used to be kind of like beta blocker, diuretic, that's it, don't do much. Now with the SGLT2s, I'm using more of those. So I think it's still a little bit of a black box, but again, I think it needs to be individualized.
So most of your heart failure patients have preserved ejection fraction, is that what you're saying?
Yeah.
I have two kind of cardiac related or cardiac rehab related questions for you. On the one, do you think the time span of the study had anything to do with your outcomes? Because I think particularly just from an exercise adaptation point of view, older people respond so much slower. Do you think you would have seen a more significant or any sort of a change if you'd gone out to like 6 months?
It's an interesting question. Yeah, and some studies actually have done long-term follow-up, so like 12-month follow-up. We weren't funded to do that. The reason we chose 3 months is because that's what traditional rehab programs do. And I don't know where the 3 months originally came from, but we just wanted to mirror that 3-month duration. But
Clearly easier to get compliance and all
Yeah.
that as well.
yeah, but there might have been accrual effects over the long term. We just don't know.
Second on that would be, I'm fascinated with the idea of trying to bring cardiac rehab mobily. But one of the things I'm also interested, do you think the remote versus in-person with the isolation factor that's so common as people age, do you think that the effectiveness of in-person could be more significant as people age to become more isolated?
I feel like there is, so I attend cardiac rehab once a week. And I see patients show up to the rehab, and sometimes like they get along, and there's this communal aspect that I think is really important to people. And so, and even like the moving analytics, like that slide I showed where they were like kind of trying to sell their software, it's just this guy like sitting in a room alone with his iPad. And I don't, it's almost like the in-person program, if you can go there and engage, almost from a wellness standpoint, it's like you've had a major event, and if you've had a heart attack or cardiac surgery, and I think that support, which is hard to quantify, that you get from other people and you get from just interacting in person is very, very important. And I think that might be missed in some of the discussion about how we can replicate that remotely.
Everything online, John?
Yes, thank you, Dr. Dodson, for that great presentation. So this is a similar question to what Jason just asked, so I'll read it, and if you could add to it, feel free. But the question is, could the social aspect of cardiac rehab be more of a motivation for older patients versus younger ones?
Yeah, I mean, I think again, socialization is important. Getting back to what I showed the island of Okinawa and how they have more people over 100 than anywhere else in the world. The theories behind that are diet, healthy lifestyle, including exercise, and actually socialization. And actually, apparently they never retire. Like they just keep working. And there's this concept in Japan called ikigai, which is something that gives you meaning. And so it's like they don't let go of that and just say like, oh, I'm just gonna like do nothing. They stay engaged in their community, and they stay socialized. And I think there's the potential for that in these rehab programs where people can socialize with others, and it's probably more important in an older population that doesn't necessarily socialize a lot. So good question. Yeah, it's fascinating.
Anything else? Well, thanks, John. Great talk.
Okay, thank you.
Great,